steps the ministry has taken to ensure access to Linda Mama services in under-resourced or understaffed health facilities, and how it is addressing barriers faced by mothers in remote and hard-to-reach areas under SHIF structure. Mr. Speaker, I submit my questions.
Honourable CS, you may now proceed to respond.
Thank you, Mr. Speaker and Honourable Senators. Let me, Mr. Speaker, first apologize, and I think it's on my side that going forward I will comply with the standing orders and provide the answers, not even 24 hours, but 48 hours. These I even had to raise with my staff this morning, and it's an oversight. It will never happen again. Honourable Speaker, on the first question, on why, what is the current annual budget, question one, which the Senator has said, my answer is this. The Linda Mama program is not currently administered under the Social Health Authority infrastructure. While the program was instrumental in expanding access to free maternal care, it is important that it faced very critical challenges that necessitated a shift to a more comprehensive and sustainable model. And these were all anchored in the 4 laws that were passed by this House. These challenges, Mr. Speaker, included frequent financing constraints, budget cuts, delay reimbursements, significant access and equity gaps, especially for adolescent mothers without identification, and a benefit package that was not comprehensive because it was excluding critical maternal and newborn services like complications and the NICU care. And in response, Mr. Speaker and Honourable Senators, the Ministry of Health, through the Social Health Authority, has adopted a very comprehensive household coverage model to ensure all vulnerable families can access a broader range of essential health services. And that's why, as part of this strategic framework, the national government, through SHA and the Ministry of Health, is sponsoring 558,000 indigent households, which were identified through the State Department for Social Protection Enhanced Single Registry in order to access healthcare under SHA. And this is ongoing. Governors have come in, members of parliament, and many other philanthropists are coming in to support this program. Furthermore, recognizing teenage pregnancy as a very critical public health challenge in our country, the Social Health Authority has also introduced a very deliberate, targeted intervention for adolescent mothers and their newborns, leveraging digital health platforms and using our community health promoters. SHA now can facilitate real-time registration of these vulnerable groups, ensuring equitable access to subsidized care. And I'm happy to report that to date, 22,000, since SHA came into being, 22,000 teenage mothers across our country have accessed maternal services free of charge. The allocation of funds now operates on a fee-for-service model where funds follow the patient via claims, and this has replaced the previous fixed pre-allocation sort of budget. Question B was on the benefit package of Linda Mama. Honorable Speaker and members, the transition under SHIF has significantly expanded the former Linda Mama benefit package from a very narrow maternal focus to a very comprehensive household coverage model, now known as Linda Jamii Scheme. While delivery services remain very central, reimbursement has improved through a fee-for-service model, and which is aligned with the actual service cost. And this has given us and strengthened inclusivity for all vulnerable households across our country. And the table, Honorable Speaker, that I have provided shows the scope of coverage under Linda Mama and under the new SHA program. I really don't want to go. It shows the reimbursement model, the eligibility, the scope of coverage, and if I pick on, for example, the scope of coverage, under the, before Linda Mama, this was limited to maternal health, ANC, formal, and C-section delivery at our primary network centers. But under SHIF and SHA, comprehensive household coverage, which include outpatient, inpatient, emergency and surgical care, chronic disease management, maternal and newborn care, including all the complications, is now covered under the Linda Jamii. If you look at the reimbursement model, Honorable Speaker and members, under the Linda Mama, there was a predetermined fixed rates paid by NHIF. There was, the fee for normal delivery was $2,500 for level 2 and 3, and $3,500 for private and faith-based level 2 and 3, and $5,000 for public facilities, and $6,000 for faith-based facilities and private level at level 5 and 6. C-section was Kenya shilling 17. But if you look at the fee-for-service model under SHA, SHIF, the facilities reimbursement is based on the actual service rendered at the approved tariff rate and passed by the House. And then there's standardization of the reimbursement. Now, both faith-based, private, and public, women can access normal delivery, and SHA will reimburse $10,000. For cesarean section, $30,000 because of equity, whether they go to public hospitals, whether they go to private hospitals, whether they go to faith-based hospital. And then eligibility is different. Under the Linda Mama, eligibility was only targeting pregnant women nationally, but adolescents and undocumented mothers were often excluded. But now if you look at the Linda Jamii or the SHA SHIF, under this transition, indigent households are identified via a very proxy mean testing as per the law, as per Section 27 of the Social Health Insurance Act of 2023. So pregnant, adolescents, and newborns are all included through a very targeted intervention using a temporary ID, and the entire household is covered under the SHIF comprehensive. So where the teenage mother can either use her birth certificate, she can use her parent identification, and the system has created a special ID to identify those important section of our mothers who are the teenage mothers. Question 3 about the safeguards. Honorable Speaker and members, several safeguards have been initiated to ensure that the funds allocated to sponsored indigent programs are used exclusively for maternal and child health services, and that vulnerable mothers receive full benefits without undue delays. And what have we done? We have done, number one, we have introduced legal and policy safeguards. The Social Health Insurance Act of 2023, which this House has passed, mandates proxy means testing to ensure that only eligible vulnerable groups are covered, and this is anchored in the use of the funds within Section 27. 2, and more important, digitization and transparency. Reimbursements are processed through digital platforms that validate service for payment. They minimize fraudulent claims. Real-time registration is done through digital health platforms. Our community health promoters help us to instantly enroll, to ensure timely access, especially in the most remote part of our country. Then there's equity and beneficiary safeguards. SHA has given priority to the most vulnerable households to ensure that the once registered indigent beneficiaries are entitled to maternal services free at the point of use, without facilities prohibiting from levying additional fees for covered services. And finally, I think the other question was, what has the ministry taken to ensure that access to Linda Mama services in the under-resourced, understaffed health facilities, and how it's addressing those barriers which are faced by our mothers. Honorable Speaker and members, to ensure access to maternal service in under-resourced and hard-to-reach areas, the Ministry of Health, through the Social Health Authority, has implemented the following measures. Number one, digital registration deployment. SHA has deployed real-time digital registration platforms at all of our over 10,000 contracted health facilities countrywide, both public, private, and faith-based. And this allows pregnant women, including those in remote areas, to be enrolled instantly and granted immediate access to services without the administrative or financial delay. The second one is the community linkage through the community health promoters, who have been empowered to identify, to register, and to link pregnant women, particularly the adolescents and the vulnerable households, to the nearest accredited facility. This strengthens the last mile access, and it will ensure inclusion of mothers to hard-to-reach areas. Lastly, Honorable Speaker and members, we are targeting the under-resourced facilities. And how do we do this? The increased and the standardized fee for service tariff for maternal services is designed in order to create insensitize both for the private and the faith-based facilities in rural areas to remain contracted and sustain quality maternal care. And that's why I am very specific that in some of our most remote rural parts, the faith-based health facilities are available, and that's why we don't want to discriminate. Our mothers can go to either faith-based facility, they can go to private, if the public facilities are not available in that area. And then the last one is to provide evidence of the outcome achieved through the Linda Mama program since inception. Honorable Speaker and members, investing in maternal and child health is a proven strategy for improving the outcomes data from the Kenya Demographic and Health Survey, which demonstrates progress, and it attributes in part to increased access facilitated by the preceding program. And reduced maternal mortality. The maternal mortality rate declined from 362 deaths per 100,000 live births in 2014 to 355 deaths per 100,000 live births in 2019. Mr. Speaker, I am very ashamed to say that figure. There are many, many mothers. Kenya should not be at 355 per 100,000, 355 mothers die for every 100,000. Our peers, our regional neighbors are doing better. But the biggest problem I have for now is that even the data is old, is the data of 20 2014. Now, what we have done at the Ministry of Health, we have decided to do our own in-house data. And we must ask this House and the whole country that it should not be business anymore, that we can talk of maternal mortality rate of this figure. Mothers, when they walk to facilities, they are not patients. When they walk to facilities, they walk to facilities to go and give life. It is immoral, it's unconstitutional, and I think it is not acceptable for us to have this kind of high maternal and child death in our country. And I think at the highest level, from the presidency to the ministry, to the houses of parliament, to the leadership, all of us stakeholders together, we must discuss this openly. And what we are also trying to do now, that we have digitized our healthcare system. In another 3 months, we will make it mandatory that every health facility in our country, be it private, public, faith-based, they must report maternal deaths and child deaths on a daily basis through a dashboard. 2, I think the Linda Mama has helped us lower the infant mortality rate. The infant mortality rate has decreased from 39 deaths per 1,000 live births in 2014 to 32 deaths per 100,000 live births in 2019. Again, it's very sad that as a country we are using data of 2019 and 2014. But this was a traditional way of doing it, where we were using this data and we were doing this assessment during when we were doing census and giving it to the Kenya Bureau of Statistics. But I think going forward, as a ministry, we have a moral duty to do our own in-house every year, every 2 years, both for the infant mortality and for the maternal mortality rate. Of course, there is improved service utilization. The percentage of women attending at least 4 antenatal care visits in our country has increased from 52% in 2014 to 60% in 2019, indicating improved access. But when I walk around counties to do the SHA rollout, a number of leaders are not agreeing with this figure, and I agree with them because the data is old. The data is maybe 5 years, 6 years, 7 years. So we need to find out the correct data, and I am ready, willing, Mr. Speaker. I have set up a committee led by the Director of Medical Services, Dr. Amoth, to make sure that we get the right data. How many of our mothers die? We want to make it a mandatory that every health facility reports maternal and child deaths in our country. That is the questions for Honorable Senator Mutinda, Your Excellency. Thank you.
Senator Mutinda, do you have any supplementary questions?
Mr. Speaker. Bwana Waziri, thank you for your responses. And I want to agree with you that there is no single mother who becomes pregnant and wishes to die or even lose their child. I'm happy that you also note that. Now, I sit in the Committee of Health, and yes, Mr. Speaker, through you, we've really been visiting different counties, and recently we were actually in the Eastern region, and I want to agree that yes, when we ask the question of if SHA is working, the response is that SHA is working. I want to narrow my follow-up questions, Bwana Waziri, to part C. When I asked about the issue of the funds, your response specifies and says that Chief Act 2023, Section 27, has taken care of that. But when I look at Section 27, Bwana Waziri, it is much more on the contribution of Chief. I would want to know, Bwana Waziri, of the measures that have been put in place, that there is a follow-up from SHA that ensures that the funds that come through Linda Mama, as much as you've explained that Linda Mama is not in place, but it has been substituted, and the services are in place and are being offered. But what is SHA doing to ensure that there is a follow-up of these funds specifically for Linda Mama? At the same time, the issues of capacity building, Mr. Speaker. Waziri, you've talked about digitalization and transparency. I have noticed, yes, your team is on the ground doing the digital registration, especially to these young teenagers under 18 who have no national ID. But what capacity building measures have you put in place to ensure that even the young mothers who are not aware that they can actually get these services, they can know that these services are still being rendered? What has been put in place to ensure that there is that capacity?
Yes, Senator Mutinda, avoid speeches. Go straight to the question, please.
Okay, Mr. Speaker. I know the young mothers we've met in hospitals, they have no even phone, they have no documentation. What has been put in place to ensure that even those ones with nothing are being assisted with the shortest time, because sometimes they always explain to us that they have just been kept in hospital, just waiting, to hope that things will be sorted within the shortest time possible. Lastly, Mr. Speaker, is mechanisms to monitor transparency and accountability of SHA funds from Linda Mama when they are remitted to the health facilities, and how SHA is looking forward to sort the challenge that is being experienced by most of the health facilities, whereby there is delayed reimbursement of the SHA fund to the health facilities. Hence, they are not able to continuously sustain offering the best services that they're supposed to offer.
Honorable
Thank you, Mr.
CS,
Speaker.
you may proceed to respond.
Honorable Speaker and the members, the current Linda Jamii budget is 900 million. And this budget is supposed to cover 400,000 teenage mothers across our 47 counties. And every year, the estimates, different counties, the estimate is about, we have in our country about 400,000 teenage mothers. And they are the ones who are to be covered by this budget. So far, from our record at SHA, through digitization, we have covered 22,000, paid for and went home. The question is, how do we trace them? How do we get them? We have the numbers. We have counties with the highest numbers I can give. We have counties with the lowest numbers. County like Kakamega, Kilifi, the highest numbers. What are we doing to make sure we mobilize? We are talking to governors, we are talking to leaders, both political, church leaders, and we are mobilizing a very robust registration of teenage mothers and going with all our county governments. Everywhere we go, we give them the numbers, and we tell them, these are the numbers of teenage mothers who exist in this county. These are the numbers who have visited health facilities and who have accessed this free service. Please help us mobilize. We are using our community health promoters, and we are even urging the House and the leaders to make sure that all of us together, we are not promoting it, but we have no choice. They are our children, and we must protect them. So, including the leadership here, we really want to make sure that we increase our number from the 22,000 teenage mothers who have already accessed and cover all the 400. To date, Honorable Speaker and members, we have 476,553 deliveries, normal deliveries. And we have another 150, 602, who went through cesarean delivery. Our community health promoters are well-trained, particularly in terms of registration of teenage mothers. And so far, the claim that SHA has paid, particularly on maternity, is about 9.7 billion to all health facilities at all levels in all the three categories of private, public, and faith-based. So if you look at what this House has passed, the Facility Improvement Fund Act, which ring-fenced funds at the facility for the improvement of those services. And these funds, to the good wisdom of this House, you have decided that the reimbursements must go direct to the facility, not to the county treasury fund, so that the facility can buy drugs, the facility can even hire healthcare workers, either on contract or locum. And all this is geared to make sure that the health facilities are managed better through the reimbursed funds in order for us to achieve key health indicators and priorities, Mr. Speaker. Thank you, sir.
Senator Mandago.
Thank you very much. My supplementary question to the CS is on the issues of reimbursement and clearance of mothers to leave the facility. Apparently, there is inordinate delay in hospitals, so that the mother can take another 3 days, and the facility says SHA doesn't cover the 3 extra days you've stayed in the facility, and that is what is bringing the trouble of detention of mothers in facilities. I'm specifically speaking of Moi Teaching and Referral Hospital, where cases have been reported to me as area senator. Apparently also I'm the chair of the senatorial committee, so I cannot escape the response. Since you are here, I think it is a good opportunity to respond to that, so that all other facilities in the country can be able to facilitate matters as soon as they are due for release from facilities. They are immediately released, regardless of the processes that the hospitals have to continue with billing and so forth, so that mothers, again, SHA doesn't pay for them, but they have stayed another 3 days and they are forced to pay, and in the process they actually pay more than SHA, what SHA is paying for them. Thank you very much, Speaker.
Senator Majayo.
Asante mstahiki Spika. Mstahiki Spika, swali langu kwa waziri wa afya ni kwamba kulikuwa na masikizano ama mkataba hapo awali ya kwamba wagonjwa watakaokuwa wanajiwasilisha katika hospitali za kiwango cha kwanza, cha pili na cha tatu, yaani level 1, level 2 na level 3. Hawa wagonjwa hawa ama kina mama wanaokwenda katika zile hospitali ilikuwa watapata matibabu ya bure, ya kwamba wakiingia pale watapewa matibabu na alafu wataenda zao nyumbani bila kulipa chochote, wakati wakiwa wao ni wasajili katika yale mamlaka ya afya ya jamii ambao ni SHA. Sasa nauliza, ni kwa sababu gani bwana waziri, katika ule mkataba ambao ulikuweko baina ya mamlaka ya afya ya jamii ambao ni SHA na vile ambavyo ulipeana mkataba huo, ya kwamba watu wakija, wakina mama, watoto, watu wazima wakienda, ikiwa wao ni members wa ile SHA, wasiweze kulipa, lakini hivi sasa tunaona ya kwamba katika mahospitali yetu wanalipa. Je, iko uwezekano wa kwamba wewe unaweza kuregesha tena hiyo amri na ukawaambia kwamba watu wote, kina mama na watoto ambao wao wamejisajili na SHA wasiweze kulipa malipo hayo, ili turudi pale pale tulikuwa zamani, ya kwamba wakipata matibabu wanaondoka, watapata matibabu bure, alafu waende zao nyumbani. Asante Bwana Speaker.
Senator Aaron Cheriot. Now, honorable senators will know that question number 116, which is the next question after this, essentially deals with matters surrounding SHA. So you may want to hold on some questions and ask them when we are dealing with that particular question.
Mr. Speaker, if that is a guidance, then I follow your guidance.
Thank you. Thank you. Senator Shakila.
Thank you, Mr. Speaker. Mr. Speaker, my question is regarding SHA. We know since SHA took over, it has been facing a lot of challenges.
Senator Shakila, I
Yes.
have just said that we will be moving
Oh,
to
okay.
interrogate matters SHA.
So
in
I
question
hold
number
my question?
116. Oh, no,
I'll do that. I
You
thought
will
you gave
get
me
an
the-
opportunity at that time.
Okay.
Senator Boni.
Thank you, Mr. Speaker. This issue is a matter of life and death, and the minister has a very good opportunity to speak to Kenyans about this. Minister, a living patient by the name of Sheila Litunya Omungala from Kakamega, Butere, working in Nairobi. She went to deliver. She had paid for SHA. She's a small mama mboga in this town and what have you. She had paid for SHA. She had done her part. But at the end of the process, she was faced with a bill of 51,000, of which thankfully SHA paid around 400,000. The remaining 200,000, they told her, you must pay. Minister, this is the room. When a poor woman like that who had played her role, she had paid, she then has to pay 200,000. Then they can't say SHA is working, because these are the same women, when she was delivering her first and second child under Linda Mama, she just went, delivered, and went back home. But in your case, she's being challenged, despite being a member, you must pay. I want to thank the Senator of Nairobi, because I had to use his office to get to social workers for me to get that bill to be waived. Not many patients have access to us leaders.
What is your
So,
question,
Minister, my question.
Senator Boni?
Yeah, I had to pay it because I feel a lot of pain about Litunya.
I share your pain, but
yes.
go straight to the question, Senator.
So, Minister, the question you must answer for Kenyans, this extra bill, which SHA expect people to pay, why don't you accept that it is a statement of a failed system of funding, and therefore you rework it so that patients, my dear brother, can enjoy in the same manner they were enjoying under Linda Mama. When you convert Linda Mama into Linda Jamii, that is fraud, because in Jamii, people, and Dr. Moth is there, some of the people in the Jamii have got backache, some weird things, but delivery of mothers is a serious emergency which is life-threatening. You've just told us about the 355 women who die out of 100,000 people. That should not happen. Governor Wamatangi has shown you the way in Kiambu. He has sustained 8 months without a single maternal death. It's doable. And because my younger colleague is there.
Senator Beatrice Akinyi.
Thank you, the Honorable Speaker. Welcome, C.S. Duale, to the Senate. And from the onset, I want to say that Linda Mama was one of the best things that happened in this country. My question is, Honorable Speaker. CS, are there health facilities in this republic holding mothers that have delivered for non-payment of bills? And what is the policy of the ministry? Because the ministry is the custodian of the sector's policy. It is sad that there are children who have to spend their first days in hospital because their mothers or their parents or their guardians cannot pay bills. Thank you.
Senator Nabwire.
Thank you, Mr. Speaker, for the opportunity to contribute towards supplementary questions to the CS. One, I would like to ask the CS that anti-D for ESA's negative was a part of the Linda Mama package, but it was scrapped off. So currently, most mothers with this condition are not getting it because of the cost. Secondly, I would like to inform that sometimes patients are not...
Senator Nabwire, you are entitled to just one supplementary question, which you've already asked. Kindly take your seat. Senator Hamida.
Thank you, Mr. Speaker. Bwana Waziri, looking at Linda Mama, unfortunately, free things also at times, they come with a price. We have going to, when we inspect hospitals, we have found shortages of staff, high workload, inadequate equipment, inadequate beds, delivery theaters are not there. And seriously, it's such a pain to see that, imagine, you have a maternity without theaters. So I'm just wondering, is there any awareness? And also looking at awareness on women, especially the young mothers, that at times the marginalized groups need to know about the right of the Linda Mama and what's covered and how and the access to Linda Mama. One last thing is that the tracking and accountability, Bwana Waziri, how do you monitor for empowerment working? How do we link that monitoring of these programs to outcomes, looking at maternal mortality? Bwana Waziri, I had a motion here in Parliament on postpartum depression, mothers on mental health. And I think my motion went through, and so I think the hospitals need to have a wing for postpartum depression, Bwana Waziri. What we found it very funny is that we've gone to many hospitals, found mothers who have given birth, and they're...
Senator Hamida.
Yes.
You have asked...
Many
questions. Kindly yield. Senator Chirange.
Thank you, Mr. Speaker. Mine is Waziri Duale. Welcome and thank you. You are doing a good job. My question will be very simple, Waziri. This transition from Linda Mama to Linda Jamii, did we at any point lose the package of Linda Mama as you transit to Linda Jamii? Can you give us the package so that you debunk the street political fraud by Senator Kalwale, so that Kenyans, this is the only forum. We don't want Senator Kalwale to go to Malinya and mislead people that shifting from Linda Mama to Linda Jamii is a fraud. You have the opportunity to shine, Waziri. I yield.
Senator Meth.
Thank you very much, Mr. Speaker. Sir, mine is actually related to what Senator Akinyi asked, and I saw the maternal deaths report, and Nyandarua had the least maternal deaths report in the entire republic. But my question was, Waziri, since most of these facilities that we have are run by county governments, my question is, in terms of detaining mothers and their newborns, is there a policy in the ministry as to how long a mother can be detained in a hospital because they're not able to meet their bill?
Senator Mungatana.
Mr. Speaker, thank you, and thank you, Waziri, for the good job you're doing at the ministry. Mr. Speaker, we pay 2.75% of gross with a minimum of 300 shillings, or means testing is done, and we pay 2.75%. Now, this is what Kenyans are paying. The question I wanted to ask you, Mr. Speaker, through the Minister, through Mr. Speaker, is that in this country, we have many other African nationalities who are living here. And maybe part of that report of deaths includes the nationalities who are living in this country from other African nations. I represent this Senate in the Pan-African Parliament. And the question is, are people covered, those who are not paying, like those who are not paying SHA now, are they covered in this Linda Jamii? What do we do with them? How do you take care of the Congolese, the Zambians, the Ethiopians, and everyone who is living here? Your system of registration says *.147#, and if you go down, the next is your ID number. These people don't have ID numbers. What do we do with them? They are with us here. They are still going to give you those maternal deaths. What do we do with them? What is the stand of the Kenya government on this matter? Thank you, Mr. Speaker.
Senator Nyutu.
Thank you, Mr. Speaker, for the opportunity. And allow me to just remind Waziri that the duties under the ministry that he has are very massive, Mr. Speaker, because you can live without an education. You can actually live, you can actually borrow some food from a neighbor, but you can never borrow health from a neighbor. You cannot live without good health. Mr. Speaker, I'm just trying to tell the CS that he would do better to work more than he does politics. That having been said and done, Mr. Speaker, I want to ask the CS, he has in his response about Linda Mama, he has said that they transited from Linda Mama to Linda Jamii. And one of the benefits that according to the response by the CS, one of the benefits is that it is covering teenage mothers. So my question then becomes, Honorable Minister, what is the ministry doing to see to it that there is prevention of teenage pregnancies in order for us to do prevention, because we have always been told that it is better than cure? That's my question, Mr. Speaker. Thank you.
Senator Gataya, more fire.
Thank you, Honorable Speaker. My question is very simple. What is the fate of thousands of Kenyans who cannot afford to pay SHA for themselves, Honorable Waziri?
Honorable CS, you may now proceed to respond.
Thank you, Mr. Speaker and members. Let me start with the question by Honorable Senator for Uasin-Gishu and the chair of the Health Committee. Yes, the matter was very unique to MTRH. That issue we have resolved. Those mothers who had, mainly they had no IDs, and but we made our own internal contingency, and SHA has paid, and we have told the CEO and the current leadership at MTRH that that should not happen again. The question to my former colleague and senior Senator Boni Khalwale, and Senator Boni Khalwale, I will not take the advice of the Senator for Nandi, because I'm here to answer questions from senators in either form. Senator Boni Khalwale is also a medical doctor. I think the case you have mentioned first must be a very complicated case of delivery for it to reach that level of 600,000. So that was a very complicated case. And SHA covered 60% of the bill. And this must be very clear. Even during the NHIF, there was no full coverage for NHIF. So SHA will cover the bit that is required by law for SHA to pay. There's nowhere where you have to pay 100%. I mean, even myself talking, I have patients. And if the bill is $1 million, SHA pays 700, then the other 300 is an obligation on the part of the family members and relatives of that patient. So, and I think we did our bit. If I go to Linda Mama, first there's no Linda Mama that exists. A transition was done, a more comprehensive, better Linda Mama is now anchored in SHA. And Honorable Speaker, I said it when I was answering the question. And in the answers that I have given to the honorable senators, if you look at it, there's a table. And I'll give you an example. Linda Mama, for level 2 and 3, were paying 2,500. For level 4 and 5 and 6, it was paying 5,000. And in fact, there was no equity. They were paying more for faith-based and private, and less for public. The highest they paid for cesarean was 17,000. Today, under SHA, it's more expanded, more comprehensive. Any delivery that takes place in our country, if you are registered under SHIF, SHA will pay 10,000 from the 2,500 of Linda Mama. So Linda Jamii is paying 10,000. For cesarean, we have moved from 17,000 to 30,000. That is progressive. And it covers comprehensively. For Linda Mama, it was only, honorable senators, through the speaker, it was only for delivery. But for Linda Jamii, it is everything surgical, anything that that mother and her child will require, even the treatment of post-delivery. Under Linda Jamii is very comprehensive. I have given the data, and you can look at it. 2, it was budgeted, so the budget was not predictive. We inherited 4.2 billion shillings debt of Linda Mama. Today we will not inherit anything. Today we have no bill. Every mother in our country